Welcome to NSC 222, Study Session 6, Wound Healing Process. Introduction. Wound is a disruption of normal structure and function of the integument or a break in the continuity of the skin and soft tissues. Most of us at one time or the other have sustained injuries on different parts of the body. This one took some time to heal, some weeks, others months, and others years. Have you ever wondered how our bodies respond and go through the healing process? This study session introduces you to physiology of healing. You will learn about the definition and classification of wounds, and also you will study the healing process of acute wounds. Learning outcomes. Define wound healing. Explain the different wound classification. Describe the healing process of acute wounds. Concept of wound healing. Types of wounds. Based on the healing process and duration, wounds can be grouped in 3 types. Take 2. Based on the healing process and duration, wounds can be grouped in 3 types: acute wounds, chronic wounds, recalcitrant wounds. Wound healing is a complex sequence of events initiated when an injury occurs and ends when complete wound closure and successful functional scar has organized, up to 18 months after wound closure. 1. Acute wounds. An acute wound is a disruption in normal integumentary anatomic structure and function commonly caused by trauma or surgery. Healing occurs within an expected duration of time without complication. Simmons and Elston, 2009. An acute wound can also be described as a disruption in the integrity of the skin and underlying tissues that progress through the healing process in a timely and uncomplicated manner. Bates, Jason, 1998. 2. Recalcitrant wounds. A non-healing wound that is stubborn, defiant, refractory, or unmanageable. Recalcitrant wounds may be static or deteriorating. Being static suggests a lack of movement towards identified goal. Healing, symptom control. While deterioration means that the wound following a negative cause or there is an active process of tissue destruction of varying extent and duration. 3. Chronic wounds. These are complex wounds which do not follow the normal processes for healing, which means they fail to progress through a normal, orderly, and timely sequence of repair. The wounds may be caused by pressure, diminished circulation, inadequate nutritional status, diabetes mellitus, etc. Healing may occur in an extended amount of time with complications. Note that some chronic wounds may be non-healing wounds. Chronic wounds are characterized by prolonged inflammation, cellular senescence, untriggered release and deficiency of growth factor, receptor sites, and high level of protease. Dougherty and Sparks, Fries, 2006. The chronicity of wounds is an indication the long-standing, persistent, and lagging status of a wound. Classification of wounds. Wounds may be classified based on underlying causes as follows. arterial ulcer. Burns, diabetic foot ulcer, incontinence wound, neuropathic ulcer, pressure ulcer, skin graft donor site, surgical incisions, vasculicite ulcer. 1. Arterial ulcer. These wounds occur as a result of arterial insufficiency to a specific part of the body, usually a limb, resulting in causing ischemia. 2. Burns. These are categorized according to extent and severity of injury. There are 4 types of burn injury: chemical, radiation, electrical, and thermal. 3. Diabetic foot ulcer, caused by trauma, pressure, peripheral neuropathy, peripheral arterial disease, and/or infection, often located on the plantar surface of the foot. 4. Incontinence wound. Damaged skin related to urinary, fecal, or combination of incontinence. This is not to be confused with pressure ulcer. 5. Neuropathic ulcer. Partial to full thickness loss caused by peripheral neuropathy, not exclusive in diabetes. 6. Pressure ulcers, caused by prolonged exposure of tissue to unrelieved pressure, shear, or friction. Pressure ulcers are staged as II, and IV to describe the depth of tissue involvement. 7. Skin graft donor site. Surgical sites where epidermis and a specific portion of the dermis have been transferred to a well-vascularized area of wounding on the body, usually a partial thickness wound. 8. Surgical incisions. An intentional wound created by surgery. Surgical incisions can be grouped into 4, such as clean, contaminated, and dirty. Clean. Minimal endogenous bacterial contamination present. Clean contaminated. Possible endogenous bacterial contamination is present. Contaminated. Contamination is present. Dirty. Infected tissue present, e.g., abscesses. 9. Vasculitic ulcer. This frequently accompanies connective tissue diseases such as rheumatoid arthritis, lupus erythematosus, Sjogren's syndrome, or systemic inflammatory diseases. May result in spontaneous infarct and gangrene. Healing in acute wounds. Acute wounds are traumatic or surgical wounds. Healing follows well-defined structured processes of inflammation, cell proliferation and repair of matrix, epithelialization and remodeling. Mnemonic VIPER represent process of healing in acute wound and reflect the tissue responses. V. Vascular phase. Initial vasoconstriction and activation of platelets with rapid fibrin plugging. High. Inflammatory phase. Increased mobilization of phagocytic cells, complement system, and antibodies to the site of injury. P. Proliferative phase. This overlaps the inflammatory phase to produce substrate for granulation. E. Establishment of new skin barrier. R. Remodeling. The phases of acute wound healing. 4 phases are involved in acute wound healing. These are hemostasis, acute inflammatory phase, proliferative phase, acute remodeling. Hemostasis. Injury causes tissue disruption and hemorrhage, filling the wound and exposing blood to extracellular matrix components (ECM). Clot forms due to aggregation and degranulation, which activates factor XII, Hedman factor, causing hemostasis. Fibrinolysis begins. Clot dissolves and cells migrate into the wound space. Acute inflammatory phase. The phase of acute inflammation is often regarded as the first phase of healing process. It begins 3 to 4 days of initial wounding. As fibrin clot dissolves, dilating capillaries become more permeable, allowing fluid into the site, which activates the complement system, a series of interacting, soluble proteins that induce lysis and destruction of target cells. This helps to bind neutrophils to bacteria and facilitates the process of phagocytosis. The number of neutrophils reaches its peak within 24 to 48 hours of injury and decreases after 3 days if no infection is present. Tissue macrophages arrive, important source of biological regulators, cytokines, growth factors, proteolytic enzymes, essential for normal healing. These are followed by lymphocytes. Refer to the study section on cellular response to inflammation. It should be noted that the major components in this phase is vascular permeability and cellular recruitment. However, if necrotic tissue, bacteria or foreign materials are present in the wound, it causes abnormal production of metalloproteinase, which alters the balance of inflammation and impair the functions of the cytokines. Further in this phase is the process of granulation, which involves the formation of proliferating fibroblasts, proliferating capillary sprouts, angioblasts, various WBC, exudates, and loose and semi-fluid gland substance. Acute remodeling. This is the longest and the last phase of healing. Collagen fibers are further organized and remodeled. Fibroblast disappears. Wound contraction occurs with active movement of myofibroblasts, which brings the edges together to close the wound. A mature scar is formed. A healed wound only regains approximately 80% of the tensile strength of unwounded skin. It takes about 180 days for the diameter and the morphology of collagen fibers to regain the appearance of the normal skin. Remodeling may continue for many years. Proliferative phase. The fibroblasts, which are immature connective tissue, are formed into the site of injury secrete collagen. Collagen is organized and structured to strengthen the healing site, fibrous or scar tissue. At this time, the wound appears pink and vascular, with numerous red granules, young budding capillaries. It is friable and at risk for dehiscence and resistant to infection. Additionally, epithelialization occurs. This is a regeneration of surface epithelium from the wound edge. Within few days, thin layer of epithelial tissue migrates across the wound surface. Epithelium thickens and begins to mature in superficial wound. Reepithelialization may take 3 to 4 days. Summary of the phases of healing in an acute wound. See diagram. Causes of prolonged phase of inflammation in chronic wound. The process of healing in a chronic wound is described below. Chronic inflammation, chronic proliferation, chronic epithelialization, chronic remodeling. In a chronic wound, the absence of prolonged inflammation indicates body's inability to present an immune response. It also suggests an individual with immune compromise. Chronicity can also occur in patients with diabetes, overuse of antiseptics, radiation therapy, and severe ischemia. 1. Chronic inflammation. Inflammatory phase persists for weeks to months. Prolonged trauma to the wounded area. Macrophages and neutrophils are not phagocytosing necrotic tissue, ingesting foreign debris, or fighting infection. Reflex hyperemia caused by vasodilatation in the surrounding vessels occur. 2. Chronic proliferation occurs when infection is present in the wound and impairs the proliferation process. The wound gets stuck and does not progress to the next phase. This may last up to 11 months. 4. Chronic epithelialization. Cells stack up on each other and present as a ridge along the wound edge. Wound edge is rolled, thick, and fibrotic with hyperkeratosis. Hyperkeratosis is an abnormality of epithelialization which represents an overgrowth of the horny layer. 5. Chronic remodeling. In this phase, there is formation of keloid scarring. Absence of remodeling may be due to intrinsic, or iatrogenic causes. A wound that does not heal suggests the absence of remodeling. The causes may be intrinsic, or iatrogenic. Scar tissue fails to form for closure of the wound. Biochemical differences between acute and chronic wounds. Characteristics: wound fluid. Acute wounds: low amount of inflammatory cytokines, low amount of metaprotease MMPs. Chronic wounds: high amount of inflammatory cytokines, high amount of matrix metalloproteinase MMPs. Characteristics: cells. Acute wounds: high cell mitosis, increased levels of growth factors, rapid cell response. Chronic wounds: low cell mitosis, decreased response to growth factors, presence of senescent cells. Summary: in this study session, you have learned that the difference between acute and chronic wounds, and the processes involved in healing of such wounds. The factors which can prolong the healing processes were also highlighted. End of study session 6. Thanks for listening.